take your seats and we can get the meeting going. Hope you all have some coffee and some Danishes, which are delicious. Good morning and welcome to the 2023 annual meeting for the Alcohol, Drug, and Mental Health Board of Franklin County. I'm Scott Doran. I'm this year's chair of the board, and I'm honored to serve in that capacity this year and with all of you remarkable folks who are helping us in the community. It's great to see so many of our providers and partners here with us this morning and to recognize the incredible work you all do in the community. ADAMH is fortunate to be part of a community that works cooperatively and openly in unique and lasting collaborations to tackle behavioral health and substance abuse, because better really does begin here. Our spirit of collaboration drives ADAMH and our many partners in our goal of assuring that equitable, accessible mental health and addiction services and support are available to each and every Franklin County resident, providing help, healing, health, and hope to those in need. I'd also like to thank my colleagues on the Board of Trustees for their commitment and guidance. And if I could ask the trustees who are able to join us to stand. Thank you all very much for your efforts. I also want to recognize the local officials and their representatives who are here with us today. Ohio State Senator Herschel Craig, Ohio State Senator Bill DeMora, Ohio House Representative Dontavius Gerals, Ohio House Representative Ismail Mohammed, Ohio Representative Anita Somani, Columbus Public Health Commissioner Maishika Roberts, and Franklin County Public Health Commissioner Joe Mazzola. Thank you all for joining us and for your efforts. We also have staff joining us from the office of Congresswoman Joyce Beatty, Columbus Mayor Andrew Ginther, as well as Columbus City Council. Thank you for all your support. In addition to ADAMH providers, we welcome some of our many essential partners, including the Ohio Department of Mental Health and Addiction Services, Franklin County officials, city and county public safety, and CODA. ADAMH's mission to plan, fund, and evaluate mental health and addiction services is made possible through the recognition of Franklin County taxpayers that these services are essential for a healthy, growing community. More than 84% of ADAMH's budget goes directly back into the community in the form of social services. In 2022, Franklin County ADAMH invested more than $90 million on community services, which are clearly needed in Franklin County. But it's really about what these investments enable: a robust system that ensures that mental health and addiction-related services and supports are available to all Franklin County residents. ADAMH funding ensures that mental health and substance abuse prevention services are available in all 16 Franklin County public school districts, that a range of residential care, supportive, transitional, and independent housing options are available across the community, and that crisis services are available to anyone in need, regardless of their ability to pay. And the families have support and places to turn for themselves and their loved ones living with mental illness. We are here today because of the commitment of more than 30 community-based agencies that participate in the ADAMH network of care. It is these frontline professionals in our behavioral health workforce to show up every day to do this challenging and rewarding work, who are the real heroes of this effort. Later in this program, we will have the opportunity to recognize some of their outstanding contributions. I would also like to recognize the ADAMH team for their ongoing hard work and commitment to make ADAMH's mission a reality. They are led by CEO Erica Clark-Jones, who I now welcome to the podium.
Well, good morning.
Good morning.
I only drank a half a cup of coffee because I did not want to leap off the stage. because I'm really excited to be here with all of you, to celebrate you, and to celebrate this work that we are doing together. So thank you, Scott, for the introduction and for illuminating our investments across our community. Many of you here today have been working shoulder to shoulder with each other and ADAMH, exploring how we can do better for the individuals and families experiencing mental health or addiction-related crisis here in Central Ohio, or just living with mental illness. As we celebrate you and our continued partnerships to improve the health and well-being of Franklin County, you must know that our investments, as Scott mentioned, over $90 million that go back into the community every year, are focused in some core areas, many that you are familiar with and you've demanded because the people you serve demand these services. They include housing, prevention, treatment, family supports, recovery, and crisis. Your ADAMH is mission focused as we reimagine the crisis care continuum, improving the community's crisis service model to ensure that we meet people where they are with the most appropriate response for their individual needs. For at least a decade, ADAMH has embraced the enhancement of the crisis care continuum. So this is not new. As a key component of our continuous strategic planning, crisis has been a focus because you've demanded it, and so have the people we serve. Making meaningful and substantial change, however, takes all of us to think differently and collaborate in new ways. None of us can do this alone. Over this past year, as a community, we have made progress. All of us have made progress in strengthening the foundation for that continuum. And yet, we still have more ground to cover to ensure that there is always someone reliable to call, someone professional to come or to respond to individuals, and somewhere safe to go. The front door to a more comprehensive crisis response is 988. 988, yes, it's finally here, is the Suicide Prevention and Crisis Lifeline. It is now available in Franklin County as the someone to call. Launched in July 2022, it is operated locally by our partners at North Central Mental Health Services and NetCare Access, both longstanding ADAMH providers. The local implementation of 988 was a collaborative effort, and I want to thank our 911 988 work group with partners including our 988 responders, Columbus Public Health, as well as 911 call center representatives from the cities of Columbus and Grove City, as well as the Franklin County Sheriff's Office. ADAMH data shows that people are actively seeking help through 988 already, with an average of 1,000 calls per month. These calls are primarily answered through North Central Mental Health Services with a team of 56 call takers. But get this, 17 are full-time, 2 are part-time, and 37 are volunteers. However, the 988 call volume represents only one of several crisis lines in our Franklin County community. So that means the calls represent only a fraction of the need. The City of Columbus's 911 Right Response Unit has triaged 3,000 calls so far this year. Over time, the success of 988 will benefit our local 911 response, freeing up our first responders to focus on public safety emergencies. And the two systems will need to work in tandem with confidence. To advance this partnership, the 988 911 work group will soon launch a pilot program that embeds 988 responders in the Franklin County Sheriff's Office and the Grove City 911 call center to develop standard operating procedures for transfers between 988 and 911. We hope that what we learn from this pilot can be shared across all Central Ohio PSAPs and eventually across the state. We also envision a day where 988 is our community's care traffic control center. where anyone experiencing a behavioral health crisis will know to call 988 when public safety responders are not needed, establishing a no wrong door approach where 988 call centers have interoperability with other Franklin County crisis lines, and where call centers can provide immediate scheduling across the behavioral health system for ongoing care. So one call will do it all. Until recently, responders, or the someone reliable to come, most often was EMS or police, simply because there was no other alternative. And we thank you, by the way. We're not saying that was bad. But we are grateful for the recent installation of the Right Response Unit at the City of Columbus because they embed clinicians with public safety teams. Public safety teams have a vital role, and when there is no life-threatening emergency or imminent threat of violence, a singularly trained behavioral health team is the preferred response. Community-based mobile teams are a best practice that is now available right here in our county. In January of this year, ADAMH funded NetCare Access to launch a county-wide pilot community mobile response program. Thanks to the additional funding received from the Ohio Department of Mental Health and Addiction Services, ADAMH hopes to double the number of community mobile teams in 2024. Dispatched through 988, these teams are comprised of a clinician and a peer who not only respond to the crisis, but also follow up to ensure individuals are connected and stay connected to ongoing services. Later in our program, our panel will provide more details about this pilot, along with 2 additional alternative mobile response initiatives operating in our community. When individuals do need a higher level of care, it is critical community members have somewhere safe to go. The future cornerstone of the crisis care continuum is the Franklin County Crisis Care Center. The construction of this center represents the community's hope for more accessible and responsive system where those in crisis are treated with dignity, provided consistent community-based care. This is best represented by the contributions of so many stakeholders, both public and private, across our region who participated in the planning and funding for the center's construction. When the Crisis Care Center opens in 2025, it will serve up to 80 individuals at any point in time and offer critical services for adults experiencing a mental health or addiction-related crisis, regardless of insurance status and ability to pay. Construction of the 70,000 plus square foot facility is proceeding as planned, and progress can be viewed at 465 Harmon Avenue. We welcome you to drive by. This is where on Harmon Avenue, where our community vision, as you see there on the slide, our community vision for safe, accessible crisis care is becoming a reality. With completion of the Crisis Care Center and the continued enhancement of mobile response and 988, we will have the building blocks in place for a stronger crisis care continuum in Franklin County. Collaboration, along with innovative thinking, will continue to drive our community forward and provide help, healing, health, and hope for our neighbors, our friends, our coworkers, your family, and my family for decades to come. While we collectively work to improve our local system, we can and should learn from those who have made similar improvements to inform the next steps in our journey together. Today's keynote speaker, Dr. John Draper, has a unique perspective on what has been learned to date and the possibilities for 988 in relationship to behavioral health crisis response. You know, we have a lot of people here for an 8 a.m. meeting. And I know you did not come out to hear me say what I just said. You came out to hear Dr. Draper, and he's worth waiting for, let me tell you. Dr. Draper has more than 30 years of experience in crisis intervention and suicide prevention work, and is considered an international expert in behavioral health services, including hotline, online chat, and text services, which, if you talk to anyone under the age of 25, is their preferred method of connecting. He began his career as a psychologist, directing a Brooklyn-based mobile crisis team before joining what is now Vibrant Emotional Health to launch New York City's first 24/7 crisis hotline. Dr. Draper led the development and operations of the National Suicide Prevention Lifeline, which he oversaw as its executive director through the launch of 988 in July 2022. In that same year, Dr. Draper joined Behavioral Health Link, Inc., a national leader in crisis services. As president of Research and Development, he continues to apply research, data, and technologies to improve the quality of crisis care systems across the continuum, not just locally, but nationally. It's an honor to welcome Dr. John Draper not only to Columbus, but to the stage.
Thank you. Wow, aren't you all so lucky to have Erica as your outstanding leader here? She's amazing. Amazing. I had the pleasure of spending time with Erica last night and a number of your leaders here in the community that are really dedicated to collaborating to bring 988 to full fruition. And we can't keep our promise of 988 unless we collaborate. And you all have really shown a great deal of collaboration to get you where you are today, which is a very impressive place. When we talk about 988, often we're talking about what it can be in the current state, though, meaning that we often mix up what we think it will be with what it is today, and it's really just in its infancy. We have a long way to go before 988 becomes what it really can be. As you can see, I mean, I don't think after 80 years, hopefully, that it will be so old, it will be better and stronger for sure. But I think this is a reminder that we not only have a long way to go, but we have a lot of challenges in front of us. I'm going to talk about some of those challenges today. And they range anywhere from capacity issues to getting people to become more aware of what 988 is, and also making sure that we get past this geolocation concerns, which I think are more of a near-term concern, which I'll talk about in a bit. And we've got to build out that crisis care continuum, that care traffic control system that Erica was talking about. Now, when SAMHSA talks about the care traffic control or the entire crisis care continuum that we want to establish, they're very, very ambitious in their aspirations. If you look at their goals here, 2023, by the end of this year, they expect or would like to see that every single one of our states are able to answer crisis calls 90% of the time within the state. Ohio is pretty much there. Most of the states aren't. 2025, they say that's when we think we can get 80% of the folks to have access to mobile crisis services. We are not there in most states and won't probably be there in 2025. In 2027, they say we want to have 80% of people have access to community crisis facilities, crisis receiving facilities. I don't think we're going to get there probably until well into the 2030s. So these are ambitious goals, but we're pretty close, not terribly far with that first goal. Let me tell you where we are with crisis calls around the country. Now, in December 2021, we were way behind in terms of our ability to answer texts and chats. About 1 out of every 4 chats was being answered by the National Suicide Prevention Lifeline. About 1 out of 2 texts was being answered. A little over 80% of the time, we were able to answer the calls. But we need to get up to that 90% if we can. So there was a lot of funds that was put in the lap of crisis centers to make sure that they would be prepared for the 988 launch in last July. And what we saw was a significant change a year later by December 2022. Nearly 100% of chats and texts are being answered now. Unfortunately, we didn't get to the 90% with crisis calls, about 87% from 81%, but there's a reason for that. And there's also a reason why we were close to 100% with chats and texts. It's about funding. The chats and texts, most of those, the overwhelming number of those are being answered by centers, 25 centers across the country that are directly funded by the federal government through the Lifeline grant to answer chats and texts. So they put enough money in their pockets knowing how many chats and texts they needed to respond to, and so they were properly equipped with the resources to do so. However, with calls, SAMHSA pretty much depends on the states to fund and resource those local crisis centers to answer those calls. So that's quite variable in terms of the willingness and ability of states to fund their local crisis call centers. So take a look at this. This is from December of last year, and this gives you a sense of that variability. So in the navy blue, those are the states that are answering between 90 to 98% of their calls in state. And the deep blue states, 80 to 89%. So you can see that Ohio is in the navy blue, at least they were in December of 2022, and they're still hovering around that 90%. So they're pretty close to that goal. Some of the other states, not so much. Those in orange are states that are answering between 50 to 70% of the calls. And again, this is about resourcing these facilities to be able to respond to the calls for 988. Now here in Ohio, it's a different kind of model. It's very decentralized and localized. There are 19 call centers in Ohio. That's more than any other state in the United States in terms of the number of call centers responding to 988. In fact, there's about 216 crisis centers in the national network, so almost 1 in 10 of the centers in the national network are in Ohio. So this is a different model. It has some upsides and downsides, but certainly an upside of this system right now is it's been very successful in responding to calls very quickly. The average speed of answer, 19 seconds compared to 35 seconds for the rest of the network on average. So that's very impressive. And as I noted, you're answering most of the calls in state. So Ohio right now is meeting the call, meeting the challenge to respond to the needs of people who are dialing 988. How many of our states are funding what we call the full complement of the Crisis Now resources? So to the extent that they're funding not only the call centers, someone to talk to, but also the mobile crisis teams, someone to respond, and the Crisis Now model of crisis receiving facilities, that is a place to go. How many of them are funding all of them? What you see in green are the number of states that are funding all 3 of those components. It looks pretty promising, except that really what that doesn't tell you is how much capacity they have in each one of those states with those facilities that they are funding. Most of them are not 24/7 in terms of their mobile crisis services, and most of the states that are funding crisis receiving facilities have very few of them in very few counties. And we'll see that a little bit is true in Ohio as well. And this is the good news that Erica was talking about earlier that really only came to fruition, again, through a great deal of collaboration and collective vision here. I don't need to go into all of the things that make this a special service for you all. I think you already know that. But this is, I think, going to be a facility that not only a number of people are going to come in to get care, but I also think a number of stakeholders from around the country are going to visit and say, I want to do that too. It's really a terrific model that you're establishing here. And in general, Ohio and Franklin County are on the ball. As you can see here, all of the counties are covered by the someone to talk to notion of Crisis Now. 77%, nearly, this is close to that 80% mark that SAMHSA says we got to have at least 80% of people covered by mobile crisis services, and that's really the case here in Ohio. 77% is very close. Where there's some lacking is the 23-hour observation, the crisis stabilization services. These are crisis receiving facilities, and it's true of most states. Most of them do not have these higher level community-based services that are really going to be crucial to having alternatives to emergency departments. But Franklin County, by 2025, is going to have the whole thing. And that's going to be a very exciting day. Yes, Erica's clapping, and the rest of you should clap as well. It's going to be a big day when that happens. What you see here is it's an interesting resource called the Crisis Resource Need Calculator. I don't know, how many of y'all have seen this before? Yeah, it's a resource that was put together by McKinsey Institute in consultation with RI International and the National Association of State Mental Health Program Directors. And what it does is help any community get a sense of what they're going to need to provide the full complement of crisis now care, meaning again, mobile crisis, call center, and crisis receiving facility for all of your residents. And then if you put in a few assumptions, you can say, here's how much it's going to cost, which is really what basically stakeholders and legislators need to know in order to be able to invest in it. So the crisis resource need calculator this is actually, this is for Franklin County. About $144 million is what they say is going to be needed for the entire population of Franklin County. And if you relate that or compare that to the emergency department or inpatient care only as the way to treat crises, that would be a savings of about $157 million. But as Eric and I were talking about last night, it's really not about cost savings. It's what that is going to mean for people in their lives who are getting the care that they need in the right way at the right time. And this also gives you a sense of how many of the mobile crisis teams you might need to be able to service the entire population. 17, the number of receiving chairs and crisis receiving facilities, 72, et cetera. But you can change those assumptions to see what makes sense for your community. It's a nice resource to at least give you a head start in thinking about what it is that you're going to need for funding to keep everything sustained over time. When we think about sustaining funding, what is Ohio doing now to take care of your crisis now system? First, starting with the federal funds that SAMPS have provided you all, about $20 million to prepare for 988 for your crisis call centers. That happened for a little over a year, and now the next 2 years, you've got about $46.5 million that have been set aside for your crisis care services, but for sustainable funding over time. So we're not worried each year, are we going to be able to fund this? And as we invest in these really important resources, are we going to be able to sustain them? There is a very, I think, appealing bill, bipartisan bill by Representatives Miller and Pavligo that is being considered that has, I think, two components worth noting here. One is the cell phone carrier fee, which the National Suicide Hotline Improvement Act or Designation Act put in place. It says states can charge cell phone fees for monthly, basically a monthly fee of everyone's cell phone bill that can be used to fund the crisis care continuum. And here in Ohio, there is discussion about up to being 10 cents, which I believe is the placeholder. But if you think about that, that's $1.20 a year that everybody would be investing in for a crisis service that many of them and their loved ones are going to be serviced by. That's a small investment for a huge, huge return. The other thing I think is important about this bill to consider is the 988 administrator is also a part of it. That 988 administrator is going to be helping you all, in the event this passes, to oversee and coordinate those 19 centers that are doing perhaps very different things to make sure that they do something uniform for everybody so your services are not so radically different based on the county that you're in. So having that uniform set of standards, that uniform oversight, those uniform expectations while still maintaining some of the individuality and the local politics and needs of those specific communities without people having to feel like they're being treated differently because they're in a certain county is really important to have. And having that 988 administrator may allow you all to do that. So again, this bill seems to me to be a very attractive one. What are other states doing? We see about 8 other states that have already enacted this cell phone fee. There's about 29 that have set aside appropriations for 988 services. About 14 states have established a 988 state trust fund. 7 states are studying 988 financing or gaps in crisis system capacity, et cetera. These are, there's a lot of different considerations that states are really dedicated to be looking at right now so they can sustain funding over time. So we don't have to every year wrestle over what are we going to do to keep our crisis services in place. And we're going to need to wrestle with that because we have a lot of challenges ahead. First, starting with capacity issues. We know we're going to get more calls over time. Right now, we don't have this saturated media campaign that is creating an awareness of 988, but over time we will. And this is a projection that was put together by, when I was with the folks at Vibrant, along with the McKinsey Institute. We projected out over 5 years if there was going to be a media campaign that was dedicated to promoting 988 that was saturating both print, online, and broadcast media. In the first year of this campaign, it would be about double of what we're getting now. We have about 5 million contacts last year. This would be, they think, after a year of a saturating media campaign, it would be about 9 million. After 5 years, 5 times that amount we expect could be close to 25 million, and this estimate is 24 million. And we know that there's a lot of people who don't know about 988. All the people in this room know about 988. We are in the minority. 87% of the people who were surveyed, these are adults, by Pew Trust, who did the survey back in May. 87% said they didn't know what 988 was or what its purpose was. And when they were told what it is and what its purpose is, about 7 of 10 of them said, yeah, I'm somewhat or highly likely to contact it. So imagine that there's quite a number of people out there who will contact this service once they learn about what it is. And there's even more of a need not just to make people aware of the service, but educate them about what it is, because there's still a number of people who won't contact the service, who are going to be saying to themselves, no, cops are going to come when I call this. No, I'm going to be hospitalized against my will. No, I'm going to be charged for services that I can't afford. And no, they're going to use my information without my permission. And so we need to educate the public about what these services are, in addition to what they're intended to do. Another big challenge is, which some of you are very familiar with, is the geolocation challenge. And I believe this is a temporary challenge. Geolocation, I'm not sure how many of you know that how the Lifeline calls are routed? Okay, they're routed by area code. And we know that, how many people here have cell phones where your cell phone is not in the local area code, your cell phone number? Yeah, so if I'm in crisis, I move here to Columbus, and if I'm in crisis, and my phone its prefix is Brooklyn, and I need help now, I'm gonna call 988, and I'm gonna get answered in New York. And all that money and all those resources and all that dedication and collaboration that you've put together to build these resources that are so specific to this county, I ain't gonna get them. And if I've just taken an overdose and I could be dying, and I can't even tell you where I am because I'm so out of it, they can't find me because they think I'm in New York. They don't know I'm here. And if you give my number to 911, they may not be able to find me either. So this is why we need to address geolocation. And there's 2 types of geolocation issues that we can look at. One is what we call coarse geolocation. That means just get me to the nearest cell phone tower. If you can just connect the nearest cell phone tower to my call, that will put me to the nearest call center, and then I can avail myself of all the local resources. That's great. Even better is fine geolocation, which will this is what 911 has, which will be able to tell the operators exactly where I am. So we can actually keep our promise when we say we're going to save people's lives. Because in the example that I just gave you, we can't necessarily keep that promise unless we have fine geolocation. I do believe that coarse geolocation is on the way. I've heard from the folks at SAMHSA that they believe sometime, probably within the next few months, that this is going to be very doable. It's probably a longer road to hoe for the fine geolocation. Other two issues worth noting here in the crisis care continuum challenges is first interoperability efficiencies and also issues related to good care and making sure that we're providing good care in the crisis care continuum. Interoperability challenges, first from the standpoint of 911 to 988. We were just hearing Erica talk about this, which I think is fabulous for Franklin County, and most areas, most PSAPs and 911 centers do not have this, which is a model where you can take non-urgent behavioral health crisis calls and deflect them over to the 988 center. And that's going to be really crucial for us to be able to give people the right care who still don't know about 988, just know about the other three-digit number. And so co-locating some of the staff members from the crisis center in the 988, in the 911 center is a terrific idea. There's also ways in which you can just triage it at the front end, not as efficiently, but you can do that and send it over to 988 centers. Also, 911 centers have got to be able to be prepared to provide for 988 centers who've made 911 calls to tell them what happened to those 911 calls. So we know when police respond, did they pick them up? Did they even see them? A lot of times they don't even see them. They bolt. So did they actually see them? And if they did see them, did they transport them to the hospital? And if so, which hospital? So we can send information to that hospital that tells them about why we called 911 in the first place. And all of that really is crucial to maintain the continuum of care of people who are at the highest risk. We also need to be able to determine what's 911's role in generating mobile crisis dispatch. And should they do it directly? In some cases, all cases? And should they do it from the 911 center, or should they transfer it to a separate mobile crisis dispatch center? So likewise, 988, in their relationship to 911, also has some interoperability challenges. As I mentioned, there needs to be that seamless interface that geolocation really, that problem underscores, which is if a person really needs help now, we got to be able to find them, and we got to be able to work with 911 to be able to find them now, or they could die. We also need to be able to obtain the disposition status from 911. I was just saying 911 needs to be able to tell the crisis call centers what happened to the people that they called 911 for, and likewise 988 centers need to be prepared to contact the 911 centers and get that information so we all know what happened to make sure that this person is taken care of. We also need to have training and collaborations across systems so we know exactly what the police are going to do and we can explain that to the people that we need to call, saying, hey, the police, when they come, they're going to be doing this. And we also need to be able to train law enforcement officers and 911 dispatchers about how to work with people with serious mental health issues. Finally, with 988, is mobile crisis dispatch, should that be happening directly from the crisis contact center, or should that be an external resource that is just in charge of mobile crisis dispatch that the 988 center contacts and has them take care of? I personally don't love that model as much. I think that's a person telling the story twice. If we have one story being told at the crisis call center, I think that's a much more efficient way of determining dispatch and dispatch levels. So for standards and practices, we do know through years of evaluations of Lifeline call centers what it is, what good care looks like, and what it needs to be in order to be able to reduce risk of suicidality. We don't have such standards and practices or evaluations for mobile crisis teams. In fact, most mobile crisis evaluation studies are decades old. So here are the kinds of things that we do need to establish for mobile crisis services in the coming years. What's the response time? Should it always be 60 minutes? What about for rural areas? Same thing as urban areas? Is that always appropriate to have, if you have scarce resources, to expect all of them to be in 60 minutes? What happens if some of them are better if you schedule them in advance? What's the appropriate time for the person who wants to receive them? And in some cases, if we have various dispatch levels, if a person's at lower risk, can they wait as opposed to people who are at higher risk, so we can make sure that they get that immediate response time. There's no data on this at all, so we're just taking a shot in the dark and say, everybody, one size fits all, 60 minutes response time. Assessment standards. We have assessment standards for suicide risk. We do not have assessment standards for risk to others. Should there be a standard or assessment principles for that as well? And for people who are seriously mentally ill or have serious disabilities, to what degree do we have some assessment principles or standards that help us determine what their level of care is? That's important for mobile crisis, but there are no national standards for that. What works for mobile crisis? We don't know. And so we don't have standards for that. We'd also need to know, once we know what works, we need to be able to monitor that care to determine if it's actually happening. We're not monitoring that care either, because we don't know what to monitor for. And in terms of training for best practices, because we don't know best practices, we do for crisis call centers, we don't know them for mobile crisis, so we don't know how to train our mobile crisis teams. And what should be the functional capabilities of mobile crisis teams? What should they all be able to do? Should they be able to dispense medication? Should they all have peer support? These are all things that there are no national standards for. There's suggested guidelines, and some of those guidelines have a lot of holes in them. But again, we do not have national standards. We should have standards for keeping our staff safe in the community, who are in the community helping people. We have no standards for that. And we should have uniform dispatch levels, going from lowest risk to highest risk, that helps us determine what mobile crisis teams should be dispatched, under what circumstances, and when should the police arrive. But we do not have national standards for that either. Lastly, I want to note what I think is going to transform in our behavioral health care system as a result of 988. For years, crisis services, suicide prevention services have been on the periphery of behavioral health care systems. They've been either in crisis call centers or in inpatient facilities or emergency departments. If we bring together, as we will with 988, suicide prevention services and crisis services, and we integrate that into the behavioral health care system, a lot of the things that we do and we've learned in crisis care systems and suicide prevention work will become part of the continuum of care. I'm very excited about that we will become one. We will learn a lot from behavioral health care system, and they're going to learn a lot from the crisis care system. One thing that they're also going to learn is how to operate differently. They're going to need to operate differently in behavioral health care systems, because people are going to enter that front door of 988 with different expectations. They're going to think, I could get care at home. And often, they should be getting care at home. It shouldn't always be happening in offices. Yes, in some circumstances, it should only happen in offices. In other circumstances, it absolutely should be happening in the home. It's rarely happening in the home. There are very few behavioral health care services occurring in the home. And also, when and how to get that care, 24/7, I ought to be able to occasionally zoom in. I should have that telehealth option. I should be able to chat or text with my practitioner. I should be able to connect with them in different ways. Right now, you just got to show up at the office at a certain time, and that's when we're going to contact each other. So these expectations will change the way in which I believe a lot of our behavioral health care systems operate. We're also going to be collecting a whole lot more data about what people need in the systems and what they're not getting in the systems. So we're going to learn essentially about new services that are not there, that we have not even thought of yet. So I imagine in 10, 15 years, we're going to be talking about very different services beyond the three that we just talked about. We talk about call centers, we talk about mobile crisis teams and crisis receiving facilities. That's just the tip of the iceberg, I think, over time. We're going to have a lot more of our workforce that's going to be interested in crisis care. Just like when 911 came along, a lot more people learned about emergency medicine. There's going to be a number of folks who are really turned on by this notion of working with people in crisis. I never received any education any guidance. I knew nothing about crisis care when I was in graduate school. Future graduate schools will be talking about 988 and crisis care in a way that we didn't even know about 20 years ago. And I think overall we will see a reduction in stigma in mental illness and mental health. I imagine that 25 years from now, I will have grandkids, maybe even great-grandkids saying, really? Is it true that cops used to come to your door if you were thinking about suicide? And again, I think that, as my daughter said, when I asked her about 988, when she was 18, what she thought about this 3-digit number, she said, Dad, I think it's going to do more than anything that we could ever do to eliminate discrimination and stigma with mental illness. And I said, why is that? And she said, because we know with the 3-digit number for medical emergencies that those are real, but people just don't know that psychological emergencies are real. So they're going to learn that they're real and they require a really different response. People who really care. And that's all the folks in this room. Thank you for joining me today.
Thank you, Dr. Draper. That was a lot of really great information to help us as we continue to build out our crisis continuum. Good morning, everyone. I'm Sue Valillo. I'm Vice President for Clinical Services at the ADAMH Board. We are now going to move to a panel discussion about mobile crisis. These are teams as well as others operating in our community, and they are a critical next step to the 988 Suicide and Crisis Lifeline. When a crisis cannot be resolved on the phone and an individual is in need of in-person intervention, that is where the mobile crisis response teams play a role. Joining Dr. Draper on stage are representatives from 3 programs in our community. I am pleased to welcome to the stage Sean Daniels, Mobile Crisis Manager, NetCare Access, Valerie Coleman, Valerie Coleman, Peer Supporter Specialist, NetCare Access. Sergeant Matt Harris, Columbus Division of Police, Mobile Crisis Response Teams. And Jessica Michael, Clinical Lead Supervisor, MRSS, Nationwide Children's Hospital, and serving as and serving as moderator for the panel is ADAMH CEO, Erica Clark-Jones. Thank you.
Good morning again, and thank you for joining us for this panel discussion. I have a lot of respect for everyone on the stage. So we have a number of mobile response teams in our community. 3 are represented here with us today. Sergeant Harris, Sean Daniel, and Jessica, would you please share a brief description about your organization's mobile crisis response and include the composition of the team, hours of operation, and how they're dispatched? You can go first.
Okay, all right. So I oversee the City of Columbus Division of Police Mobile Crisis Response Unit, and we are composed of a police officer driving a cruiser, and then we put in the passenger seat a licensed mental health clinician, and that's called the embedded co-responder model, and we respond all over the city to psychiatric emergencies. And we've been running this program for roughly 5 years. We operate from 10 a.m. until midnight, 7 days a week.
Great. And they're dispatched?
Dispatched through, calls can come in through 911. They can come in through the non-emergency number to police dispatch, triage by our right response unit. And then we also take direct referrals. So not everything comes through 911. There are plenty of people that reach out to the teams or reach out to me personally and with a referral, which we'll then assign to a team.
Thank you. Sean?
Yes, I work with NetCare Access, and we have a mobile crisis team. Our co-responder model encompasses a social worker and along with a peer support specialist. We are dispatched Sunday through Saturday from 988, also from NetCare Access Crisis Line. But we are dispatched from Sunday through Saturday. We have 5 teams that are servicing all of Franklin County, and we are responding from 8 a.m. until 9 p.m. at night. And our co-responder model, our social workers always go out in a team of 2. We're never alone. And so we have been doing this since February.
Great.
And we have definitely seen a huge increase in our call volume, probably about 75% increase.
And that's dispatched through 988?
Yes, dispatch through 988.
Great,
Absolutely.
thank you. And then Jessica, Nationwide Children's Hospital?
Hi, yeah. So I am one of 4 supervisors for our mobile response and stabilization services at Children's Hospital. Our team consists of licensed mental health clinicians, parent support specialists, and qualified behavioral health specialists. We're starting to dip our toes also into peer supporters as well. So for an initial crisis, we're sending out a duo that always includes a clinician and then one of those other roles. And we are running currently about 9A to 9:30 p. Monday through Friday, depending on kind of how late that final crisis comes in. We might be out a little bit later, but we've been open since August of 22, and like Sean said, we have absolutely seen an increase in our runs as well. We are dispatched, our calls kind of funnel through our telecrisis team at Nationwide Children's Hospital, and that's the Franklin County Youth Psychiatric Crisis Line. And those calls are either coming from community members or they're coming from the MRSS state line up north, the Thrive Center. So.
Great, thank you. So, Dr. Draper, we heard in your talk that there aren't very many national standards set around mobile crisis at this time. But how would you either recommend or are there promising practices about how effectiveness on mobile crisis teams is being measured?
That's a great question. So right now, most of the mobile crisis teams are being judged by their diversion rates, meaning that they're keeping, to what degree are they not putting people in hospitals? That to me is not an effectiveness measure. That it implies effectiveness to the extent that it's saying we're avoiding an undesirable outcome, but it's not telling you about desirable outcomes. What's happening when a mobile crisis team is called to see someone who wants the following to happen? They want to feel less in crisis and less in distress, and if they're suicidal or they could be threatening harm to others, that they and others are safer by the end of the visit. That's also what the counselors want. Counselors are not coming to this home thinking about keeping people out of hospitals. If they need to go to the hospital, that's where they need to go. What they're thinking about is, how can I help? So what are our measures for determining what's reducing distress, what's reducing suicidality, what's stabilizing people in their home, and to what degree mobile crisis services are linking people to care? Those are the kinds of effectiveness measures that we need to establish for all of our teams and everywhere they operate.
Hear, hear. Hear, hear. I'm going to turn to Valerie now, and Jessica, I'd like you to weigh in too. But we're talking about peers, right? And these emerging models all include a clinician plus a peer. Valerie, how does your unique role as a person with lived experience make a difference in individuals' outcome? Kind of what Dr. Draper was talking about. What is your role in helping make sure we're getting a better outcome for the person?
I'm Valerie, of course. I feel that my contributing factor to going out is that I have walked in their steps, and that I understand the fear, and they're safe to talk to me. I'm not gonna judge them. I'm not gonna, write down anything against them. And I can also reach them where they're at. And I know that people that have, if you have depression or something like that, another person has it. It's just like an automatic thing. So I think that it has been I've been very successful in getting people to go to the hospital or go to treatment, especially if you're at this level of you just can't go on anymore. And I try to let them know that you are in charge of what your treatment or what your outcome is going to be. I can't tell you what it should look like for you, but the first step is to get there. And I think the clinician with me is able to come from another perspective.
Great. Thank you so much. And Jessica, what are you thinking about? You're talking about parent peers, correct? How are you planning to use them?
Yeah, so our parent support specialists, we've been so fortunate to have them since we went live, and everything that she just said, they're able to get in there with the family, build those relationships, really quickly be able to build trust and rapport with the family and provide that support to the caregivers, whoever that might be, because we're not just treating the child in our case. We're kind of a family-centered care model, and we need to treat the whole family and give them that support. So it's just been fantastic to have them and have them be there. And I think also, kind of to piggyback on what you were saying, they're able to provide the clinicians and all of us other roles a lens that we might not otherwise have. And we're able to really kind of get that perspective from them and hopefully provide that better family-centered care.
Absolutely. It's so important. It's so complex as well. But you all make it look easy. Before I go to Sergeant Harris, I want to first come back to Sean and Jessica. Maybe you can kind of keep the mic here. But when your teams are on site, what is the resolution of the situations that you are encountering most? What is the disposition of the individuals we're serving at the end of this visit?
Okay, so there's a variety of dispositions. Truly, when we go out, we have a licensed professional social worker that is going to assess the client just to find out where they are in that crisis. We're going to determine what is needed for this client. So that's our first goal, is to try to figure out what treatment is needed and sometimes required. Sometimes that can be a hospital. Sometimes it can be remaining in the home, pulling in other providers, other support family members. But it is definitely trying to meet the client's needs first and foremost in the least restrictive way. In the least invasive way. We want the clients to be able to determine that they are safe, that they are safe to reach out, but they are also safe and they are in charge of choosing where they go and what kind of treatment is received. So we allow them to make those requests known. We allow them to lead the process. So again, there is a variety of things that happen. Sometimes it is the hospital. Sometimes we do leave you in the home. But when we leave you in the home, we never just leave you and abandon you. We are coming back. We're going to circle back, and actually multiple times. We will circle back to make sure that we are addressing your mental status, that you are still remaining safe while you're waiting to get connected to treatment, while you're waiting to get maybe an appointment moved up for counseling, for therapy. We are waiting for whatever provider was recommended, that they are following up with you. So we try to make sure we're closing all of those gaps to make sure people are not left feeling like, okay, you made me a referral and now you're gone and I'm here and here we go all over again. Sure. So we definitely want to try to close that gap.
And are there times when you make referrals to your stabilization unit?
Absolutely. Absolutely. We still definitely always have an option to be able to bring them into our crisis stabilization unit where they're able to get treatment. They're able to get started on medications if needed, get back on medications if needed, get linked to treatment. Again, linkage is key here for a lot of individuals, but they just don't know how to get it. And when they do call, they get put on really long wait lists often. And so it's just sort of like trying to fix the system that is broken. And so we're out here trying to connect with our clients and get them into whatever treatment is needed. When they come into our crisis stabilization program, they can be there for up to 3 to 5 days, again, where they get more follow through.
Great. Thank you. Jessica, anything you would add to that for kids?
Yeah, I think in our program, everything Sean just said as well. And we also have kind of this 6-week span of time that following the initial crisis that might actually take us a couple days to stabilize, we're able to continue to come back for up to 6 weeks, whatever the family needs. That could be every single day in that 6 weeks. It could be once a week, whatever it takes. And we're really able to work on building those coping skills and all of those other interventions that they might need to continue to stabilize in the community. And then, like she said, with linkage, just making sure that they have all of those pieces in place. It's a tricky system, as we know. So that's what's been really fortunate to have all that time to work with to make sure they're set up for success.
Awesome. Thank you. Sergeant Harris, I know you've been waiting for this. So you all implemented a new co-responder model in the last year. And what are the barriers or the challenges that you see, things we can still work on as a community? Or you can talk about it as you see it inside the division.
So I'm going to talk about the barriers from the perspective of a public safety professional who's answering 911 calls, right? So inherently, when people are calling 911, it's not because everything's okay. It is an absolute last resort for most families. People don't want to call 911. Like the doctor said, there's a great concern about law enforcement showing up. And I understand that. I completely get it. From the context of these emergent scenarios where there are dangerous things potentially happening right now in the moment. Okay, I'll tell you the things that I see as barriers on the ground doing this type of work. And so I've got a couple bullet points. None of these are going to surprise anybody. I'm sure that these are going to sound very familiar. So the biggest thing that we see once we get that crisis stabilized, once we de-escalate, once the person, potentially puts a weapon down, climbs off of the roof of a building, whatever the case may be, opens the door where they've been barricaded inside of a bathroom for 3 hours, and they're endorsing suicidality. So once we work through all of those things, the main barriers are human resources, right? Sean mentioned that. The doctor mentioned that. It's no secret that Ohio has a huge shortage of psychiatrists. It is no secret that the wait lists for services, whether that is talk therapy, whether you need your medication adjusted, whether you had your first psychotic break and you need to get into to see a psychiatrist, yesterday. We hear this from family members time and time again. It is sort of a repeated theme throughout the calls that we go on. So, we get people to the hospital. The hospital's job is to stabilize and release, but closing that loop in the long-term care is where it can be very challenging. So another bullet point would be, we do have there's a handful of scenarios that are, I'll call them, high utilizers or repeat scenarios where people are trying their best and their care team is engaging them the best way that they know how. However, sometimes it's rare, but there are times where an individual's needs just cannot be met in the community, and long-term care is what is required. Those options are very minimal throughout our state. We hear this time and time again, and it's a sad situation because 911 gets called oftentimes, 20 times in a month, going to try to assist this family or assist a mental health consumer with an issue that just keeps cycling. Yeah. So we don't have anything that I've seen, or there's a gap with long-term care. The other bullet point that I'll talk about, and I know I'm kind of long-winded here, but there seems to be a siloing of mental health care when you compare it to physical health care. Mm-hmm. One thing that I notice as I drive my cruiser all over this county and all over the city of Columbus is that there are urgent care centers on every street corner, almost like CVS, Walgreens. But there's no real option for mental health care in an urgent situation. There are a few. Ohio State has a center, and NetCare opened their outpatient clinic recently, which is great. But when it comes to the EDs, the harsh reality is that they're overwhelmed. They're understaffed. We feel it when we walk in with a patient. We feel it every time. Yeah. Some days are better than others, but I think that the siloing of mental health care versus physical health care is a barrier.
Absolutely.
And I'll stop there.
Thank you. So I am cognizant of time. So Dr. Draper, I'm going to give you the last word. I mean, this is pretty real talk from everyone up here today. As you see, you've experienced the barriers. You understand the system from a high level. What do you see as the biggest opportunities?
I think when we think about what we can do specifically for mobile crisis implementation that can really make things easier for the providers and most importantly the people that they're serving is a couple of things. I'd say one, it really helps to have uniform dispatch levels. So from 1 to 5, 5 being, let's say, under these circumstances, you have to have a police response because there is a public safety risk that has to be managed, all the way down to a 1, very low risk, which under these circumstances, absolutely mental health care workers only, and all the way up to perhaps 4, we absolutely have to have mental health voices in as part of that response, if not exclusively that response. Even at level 5, to some degree, having some kind of mental health presence there is going to be really crucial in terms of bringing down de-escalating the situation. But if we know what's required in terms of who is going to respond at each one of these levels, then we can coordinate that care, determine through, let's say, a GPS-enabled dispatch, who's closest, who can provide this kind of care, so we can get them there quickly and have the right response for the right level of need. So again, that is done in a number of states. It should be done everywhere. And you should also have a technology platform that basically brings together all of your mobile crisis teams with the dispatch agent. So the dispatch agent knows where the mobile crisis teams are, and they can send the disposition back to hopefully the call center that's on the same platform, and they can follow up as needed. But there needs to be, if we're going to talk about air or care traffic control, there has to be uniform standards, in this case disposition or dispatch levels, and a means of communicating that is basically level set across the board.
Yeah. Totally agree. So much opportunity here, so much work to do. This is what I meant by, yet we still have more to do. And I mean, you've heard it. We know what some of the characteristics of our systems, long wait lists and other things. So we have a lot more to do together. I can't thank you enough. I know we could probably talk for another hour. However, please join me in thanking our panelists. At this time, we will move to the awards portion of our program. Again, I want to thank the panelists for their valuable insights and, more importantly, contributions to ensuring better outcomes for those experiencing a behavioral health crisis in our community. As our panelists leave the stage, I'd like to welcome who I call my spirit champion, Linda Jakes, Chair of the Provider Leadership Association and Executive Director for Concord Counseling.
All right. Thank you very much for having me. I am here. Provider Leadership, just for folks to know, we are an organization. It's kind of a collaborative of all the not-for-profits within the Franklin County system that receive dollars from Franklin County ADAMH Board. And we meet regularly to kind of coordinate and enhance service provision within our system of care. So today, I'm the lucky one, I get to give out money. We are here, the Provider Leadership Association historically has given out memorial awards, the William B. George Memorial Award and the Tom Ramsire, who I happen to know, really good guy, Memorial Award. And it's given to students within the system that are kind of exemplifying great care. Students, one of the things that we're trying to do within our system is to enhance our workforce, as I work with Dr. K over there. And part of that is getting students, not only training them, but getting them in our doors and trying to keep them within the community behavioral health system. So we've got 5 of them this year. Usually we do 1 and 1. This year we are doing 5. And I would like to, and each one gets $500, which is lovely. I would say lovely. I'd be like, yeah. Yes. Tom Ramsire Memorial Award to Zandra Brown from Huck House. Congratulations. Do you want to say anything? Okay, you don't. You're good. Congratulations. We have Jackie Plunkett from Ohio Guidestone. Congratulations. You want to say something? No. Okay. There you go. Just take the money and run. Okay. We've got, for the William B. George Memorial Award, we have Mary Maskowitz. Yay! From Concord Counseling. I know her. Congratulations. You're welcome. Blessing Famul, I believe, is not here today, but I will hand this over to Amanda at the end. From Ohio Guidestone. And Tara Fretter from Concord. Hi, Tara. Congratulations. You got it. All right, so thank you very much. Let's go on with the show.
Hello, everyone. My name is Stacy Adams from North Community Counseling Center. I am the community-based director there. Just wanted to introduce as the awards today. As a past recipient of the 2020 Randall M. Dana Award of Excellence, I'm honored to able to help announce the 2023 ADAMH Awards for Outstanding Contributions. We are pleased to have the family today of Randall M. Dana. We have Nancy Dana here and Dan Hannum in attendance today. If you will, please stand to be recognized. Oh, there you go. They're over there, guys. Thank you. These awards represents a snapshot of extraordinary dedication professionals who work across the ADAMH networks. This year, we're representing 5 awards. Each award recipient works at an ADAMH provider agency. We'll now premiere this year's video highlighting the 5 awards recipients.
Welcome to the ADAMH Awards Celebration. 2023 ADAMH Awards honor the individuals and organizations in the behavioral health system who go above and beyond in their work, their volunteerism, and their advocacy to support the Franklin County community. Our first award, named in the honor of the late Barry Mastrine, recognizes an individual who promotes collaboration among organizations and inspires others to work together to improve the lives of people affected by mental illness and addiction. The 2023 Barry Mastrine Award goes to Allison Miller, the Addiction Services Administrator at The Ohio State University Wexner Medical Center. Allie is committed to saving lives through greater accessibility of the overdose reversal medication called naloxone. Under Allie's leadership, OSU Project Dawn has distributed more than 1,000 naloxone kits annually over the last 4 years. Additionally, Allie coordinated efforts across medical center and university campus locations to install Nalox box rescue kits in partnership with ADAMH. Allie is adept at facilitating change to improve the identification, treatment, and referral of patients with substance use disorders. Allie's tireless dedication to serving patients is evident in each project she takes on.
Hi, and thank you to ADAMH and my colleagues at OSU Wexner Medical Center for nominating me for this award. I'm honored to receive this award and be a partner with those in the ADAMH network and other community agencies. My role at OSU is our manager of our addiction services, and our goal is to create a coordinated continuum of care for patients across our health system and make sure that they're supported as they go back into the community. I really love working with our teams across the hospital, with our clinical and peer support staff, and also helping to build up our growing community outreach program. We really try to emphasize that recovery is possible, and we want to support patients while they're here with us and as they transition back to the community.
Our next award honors the work that Dr. Kevin Dixon championed during his 34 years of service to ADAMH, and recognizes an individual or organization who has advanced diversity, equity, and inclusion in the behavioral health space. The 2023 Kevin Dixon Champion of Diversity Award goes to Tamara Porter, Human Resource Director at Concord Counseling Services. Tamara has directed numerous changes to ensure that diversity, equity, and inclusion are cornerstones of the agency. Throughout her leadership of Concord's Cultural Competency Committee, Tamara educates staff on diversity to help them improve services to their clients, and she works to ensure that Concord staff are supported in culturally informed and inclusive ways. Tamara also has implemented processes to ensure that all individuals have fair and equal access to employment throughout all stages of their hiring process. Tamara believes in the strength, dignity, and worth of all persons. Through innovative ideas and advocacy, she has transformed the cultural competency of her organization.
I am honored to receive the Kevin Dixon Champion of Diversity Award. I would like to thank the staff and leadership at Concord for this nomination. I'd like to thank the Cultural Competency Committee for really helping us move this work forward in our agency. And of course, I have to thank my husband Joe and my daughter Taylor for always being my support system. Diversity, equity, inclusion, and belonging matters. DEIB is critical in helping us to achieve our mission of providing the best behavioral health services by instilling hope, improving lives, and serving with heart. For me, it really starts with hiring a diverse workforce in order to meet the needs of the diverse populations that we serve. It's also about making sure our staff understand how implicit biases can impact the work that we do with our clients. At Concord, we are striving to build a culture of inclusion and belonging that we think is going to really boost employee morale, and ultimately it's going to improve service delivery. I am thankful to have this opportunity to lead Concord through this DEIB journey. Thank you.
This next award, in honor of the late Randall M. Dana, recognizes and demonstrated track record of excellence in the field of clinical and client care for individuals experiencing addiction. This year's recipient of the Randall M. Dana Award of Excellence is Mahogany Harris. Mahogany has been a long-standing employee at Community for New Direction, where she currently is a case manager team lead. Mahogany has a decade of service in her field and recently assumed a new leadership role, reflecting her dedication to the Community for New Direction, its mission, and the individuals served. Her colleagues say that Mahogany is the glue that holds the substance use disorder and mental health teams together, and she strives to be a neutral voice, a leader, and a mentor. She is a strong advocate of clients with agency staff, guardians, and community supports. Community for New Direction always has new staff shadow Mahogany as she demonstrates the gold standard of how to treat and empathize with others.
I would like to thank my immediate C&D family who I work with daily. I'd also like to give a special appreciation to C&D's leadership team for considering me for this award. Being selected for this amazing award is both a blessing and a privilege. I'm so honored. Lastly, thank you to the ADAMH board for selecting me as the recipient of this wonderful award. My heart is always filled with so much joy when I see the results from the direct impact we've made in guiding and supporting some of the most vulnerable clients in their recovery. My service and work will only continue as I grow professionally.
The Artland Community Advocate Award honors an individual who has demonstrated a long-term commitment to improve the quality of life for people of Franklin County or in specific neighborhoods. This year's honoree is Stephen Willie. Steve is a member of Concord Counseling Services Pathway Clubhouse. Steve has impacted the lives of many of Pathway Clubhouse by giving his time and resources generously and consistently for more than 20 years. Steve counsels others and encourages them to seek both medical and psychiatric treatment. He also regularly sees Pathway members who have moved to nursing homes, providing a lifeline for those who feel disconnected and who may not have family or friends to visit them. In addition, he has taken on the role of medical power of attorney, assuming long-term responsibility and decision-making for others. Steve is a role model to many by being honest and open about his own struggles with mental illness. He is a living testament that with friendship and support, all things are possible.
I'd like to thank the Lord, my church, my therapist, my psychiatrist, and Pathway Clubhouse for transforming me from an unemployed, underutilized, depressed consumer who slept most of the day and watched TV at night into a working taxpayer and volunteer. It's been a long, strange journey, but I truly believe I finally found my life's purpose on this earth. The Clubhouse model really does work for those people who make the effort to give it a chance to help support them. It's a two-way street where you give your sweat and tears to the Clubhouse and in turn receive encouragement and support from the other members and staff.
Our final award is the Extraordinary Mile Award, honoring an individual or organization for extraordinary efforts in addressing the mental health and addiction recovery needs of Franklin County residents. This year, we are pleased to recognize Rick Bauman, Assistant Director of Suicide Prevention at North Central Mental Health Services. For more than 30 years, Rick has performed above and beyond expectations as both a suicide prevention hotline volunteer and an employee. Most recently, Rick helped North Central transition to a 988 Suicide and Crisis Lifeline call center. Rick has known firsthand the importance of instilling hope in those battling serious mental illness. In addition to listening to and intervening with individuals contemplating suicide, Rick has worked tirelessly with the survivors of suicide, the parents, and the families of those left behind, imparting compassion, understanding, and support in the wake of immeasurable loss and pain. For many years, he has led a support group on Sundays. Rick will go anywhere, anytime to promote suicide awareness throughout Ohio.
I'd like to thank ADAMH for this award. I'd also like to thank North Central Mental Health for supporting me with the depression support group and the survivors of the loved ones suicide groups that I facilitate. And I'd also like to thank my wife of 63 years for supporting me. Thank you.
I am Holly DeBelco-Shoney. I'm the secretary for the ADAMH Board of Trustees. And what an event today. Yes, shall we say thank you? Yeah. I would be remiss without saying thank you to the staff who have made this such a special day to celebrate the amazing things that are happening in our county. So thank you so much. On behalf of ADAMH, I'm grateful for the continuing partnerships throughout the network and across the community. Congratulations to all the winners and scholarship recipients. As we conclude our time together this morning, I'd like to invite the 2023 ADAMH Annual Award winners, who we just got to hear from in the video. I'd like to invite you forward to the front of the stage so that we can all give them a big round of applause. Please join me. As the award winners make their way to the front of the room, on behalf of the ADAMH team, thank you for being a part of our 2023 annual meeting. Thank you. To our award winners and all of you, thank you for your commitment to serving others, for being an inspiration to all of us. All award scholarship recipients, we want you to stay around afterwards for more photos. We want to document this special day. As we leave this meeting, we look forward to building upon the collaborations both within the ADAMH network and across the community to ensure help, healing, health, and hope for all Franklin County residents. Have a great rest of your day.